Good evening, everyone. I welcome you all to the webinar hosted by Delhi branch of IAP on the topic cervical spine, physiotherapeutic examination and clinical correlation, a practical demonstration. We are now starting with the webinar. I am pleased to announce that we have received an overwhelming response with attendees from more than 48 countries. A few guidelines for all our attendees today. If you have any question during this session, please put it up in the Q&A section, and these questions may be taken up at the end of the webinar by our speaker and our panelists. All your mics will be on mute mode. That means you won't be able to speak during the webinar. If you have any query or if you are having any problem, please put it up in the chat box. So I welcome you all on today's free webinar hosted by the Indian Association of Physiotherapists, Delhi branch. With that, I would like to invite our panelists, Dr. Pooja Sethi and Dr. Zubia Vakar. Dr. Pooja Sethi is a senior physiotherapist at Dr. RML Hospital. She holds a clinical experience of more than 24 years and has been awarded with various prestigious awards. She is currently the president of Delhi branch of IAP. Dr. Zubia Vakar is an assistant professor at the Center for Physiotherapy and Rehabilitation Sciences, Jamia Millia Islamia. For past 20 years, she has published papers in various reputed journals. She is currently the General Secretary of the Delhi IAP branch. I welcome our panelists.
A very good afternoon to all of you. Thank you so much for coming for the webinar today.
A very good evening, everyone. I welcome you all on behalf of Delhi branch of Indian Association of Physiotherapists. Physiotherapy practice, as we all know, is evidence-based. New researches keep coming every year, and we keep updating our treatment parameters and modalities accordingly. So as a physiotherapist, it is very important for us to keep updating and upgrading our knowledge regularly. But during this time of COVID, when we all are in lockdown and we're all confined to our homes, so DIAP is making best use of technology, and we'll be conducting many online webinars which will be on topics which will be relevant to most of the physiotherapists. And along with these, we'll be trying and inviting eminent physiotherapists who have leading knowledge in their field to share their knowledge with you, so that this journey of education does not stop here. Our first webinar today is in collaboration with Capri Institute of Manual Therapy. And it is indeed a pleasure to announce that within 48 hours of launching our flyer, we received registration from 5,264 delegates. And these registrations are not only from India, but from across the world, from more than 48 countries. We have delegates today with us from United States of America, United Kingdom, Egypt, Australia, Germany, Qatar, Dubai, Afghanistan, Algeria, Bangladesh, to name a few countries. And our speaker for today's webinar is Dr. Deepak Kumar. Dr. Deepak Kumar is a renowned name in physiotherapy in India, and in fact, he needs no introduction. Dr. Deepak के बारे में कुछ कहना तो ये होगा, सूरज को दीपक दिखाने वाली बात होगी. In his 26 years of career as a physiotherapist, he has justified many roles and responsibilities. As a teacher, to his credit, he has more than 200 talks and has trained more than 12,000 students of physiotherapy. And as a clinician, he has experience of treating more than 1 lakh patients successfully along with his team. As a researcher, he has many national and international publications to his credit. And his book, Manual of Mulligan Therapy, has been bestseller in many of the platforms. In fact, it has been translated in many foreign languages, including Russian, Korean, and Chinese. Indeed, it's a privilege and honor to have with us today. I welcome you once again, Dr. Deepak. Over to you now.
Very good evening, everyone. Happy Ramadan. And thank you very much for coming and sparing your valuable time for this webinar. Why cervical spine? Why I have selected this topic? I'm sure many of you must have heard terminology tech neck. But during this lockdown period, what I'm going to use terminology, not tech neck, but TikTok neck. Yes, TikTok neck. And you know why I'm saying this TikTok neck? Reason being, everyone in their home during the lockdown period are busy in TikTok all the time, all the time. So tech neck was only few hours they were spending, but in TikTok neck, they're spending entire day and night on their mobile phone, not even on laptop, on mobile phone. And those who are not spending their time on TikTok, they're busy in making their TikTok like this, all those facial expression and neck going into hyper extensions. So what do you expect after lockdown? Many people will be having neck pain, having cervicogenic headache, having vertigos, all those things will come all of a sudden. Many people will suffer from all those things. So because many are going to have TikTok neck, so I thought my therapist or the physical therapist should know good detail about cervical spine, assessment and treatment. In this webinar, we will be talking about assessment only. Okay, so we are going to cover the physical examination from physiotherapy point of view for the lower cervical spine. Upper cervical spine, purposely I am not including in this webinar because it needs a lot of skills to perform, and time period given for this webinar is just 1 hour. So it's a very short span to teach upper as well as lower cervical spine. Plus upper cervical spine is very, very sensitive structure. So if anyone do anything wrong, तो पेशेंट के नाम के पीछे था लग जाता है. था, समझते हो ना, था लग जाता है कि बहुत अच्छा था, टाइम पे आता था, पैसे देता था, अच्छा अंकल था, तो नाम के पीछे था लग जाता है. If anyone do anything wrong with the upper cervical spine, patient gets tha. So that's why I've selected the cervical spine. You are expecting more number of people suffering from TikTok neck. And if you promise till the last for this webinar, I promise you one thing, that a good physiotherapist after attending this webinar attentively will not require MRI to diagnose his or her patients for the cervical pain. They will be able to assess, diagnose their patient as good as through MRI. Okay, they won't need MRI films or MRI reports for this. They will be able to assess their patient as good with the help of MRI films or the report. This is what I promise you. Of course, for pathological problem, you need to go for radiological investigations and MRI for pathological condition. But what I'm talking about is the mechanical neck pain, what physiotherapists majority of the time treat. Because if any pain which is not increasing or decreasing with the neck movement, probably there is something wrong. It is the red flag, and we need to be very, very careful about it. So when patient comes to physiotherapy, essentially they should say a particular movement increasing or decreasing pain. If the patient says no movement make any difference to my pain, or it is the night pain, please go for detailed investigation, including MRI. But if those things are not there and you use what I'm going to discuss today, you will be able to diagnose your patient without the help of MRI. So please stay tuned till last and pay full attention to this webinar. In this webinar, whatever I'll be discussing or demonstrating is based on my 28 years of experience I have seen during my clinical practice, and my fellow colleagues. They agreed with me, my clinicians, my fellow colleagues practicing physiotherapy since last so many years. And it is approved by them, and they also practice the same thing. You know, I go to various workshops and I get an opportunity to talk to so many physios, and when I talk to them, they says, yes, we do the same, and we do get results. So if you're looking for evidence-based practice, no, this webinar is going to be practice-based evidence. I must tell you one interesting thing. During this Mumbai conference of Society of Indian Physiotherapists, I met Dr. Anil Bhave. That was a beautiful conference, I must tell you. Okay, so I met Dr. Anil Bhave in Mumbai during SIP conference, and when I discussed the same issue with him, you know what he said? Deepak, things or the findings may be statistically significant, but clinically irrelevant. Contrary to that, findings may be clinically relevant and statistically insignificant. I repeat, statistically significant, clinically irrelevant, and clinically relevant, statistically insignificant. Okay, so I'm going to discuss practice-based evidence in this. Of course, this webinar is in English only because there are so many participants from outside India and from South India. But you know, in between, I may speak few lines in Hindi, but you can be relaxed. I'll not be passing any technical information in Hindi. That all will be in English. I may crack certain few jokes or quotes in Hindi, and if I try to translate those things in English, you know, the punch will go away. So for my Indian physio, this is what extra they are going to get, quotes and the jokes in Hindi language. But you can be relaxed because all technical information will be given in English language only. So the very first line, don't get upset, I'll tell you in English also. एक तरफा प्यार होता है सजा, एक तरफा प्यार होता है सजा, और दो तरफ से हो तो आता है मजा. एक तरफा प्यार होता है सजा, दो तरफ से हो तो आता है मजा. I know many youngsters are smiling and laughing because they have been probably in both the situations. Okay, so it is true for this webinar also. You know, if I only speak, it's probably a punishment for me and as well as for you. But if there is a two-way communication, like I ask question and you answer and you respond, it will be good for me as well as for you. So in order to engage you throughout this 1 hour, we'll be launching few polls, asking very simple questions. There's no right or wrong answer in that. And you have to select one answer. Sorry, there are right and wrong answers. Pardon me. So you have to select the one answer only, and you will get only few seconds. Okay. So, but don't worry, I'll not be saying any name. So I'll be only telling you the percentage, that this much percentage of people think this is the answer, and this much percentage of people think this is the answer. So don't worry. So just answer as fast, as quick as you can. So it will be a good involvement for me as well as for you. And I also get to know at what level I need to discuss cervical spine examination. Okay, so let's start now. Very first thing, the cervical spine is very, very different from the thoracic spine and from the lumbar spine in many ways. And I'm sure you all know that. The shape is different, size is different, number of vertebrae is different, number of nerves are different. In thoracic and lumbar, it comes below the vertebra, while in cervical spine, it comes above the vertebra. And then in cervical spine, you get one extra nerve. You have 7 vertebra, but you get 8 nerves. However, in thoracic, 12 vertebra, 12 nerves, lumbar spine, 5 vertebra, 5 nerves. Okay, I got a signal that I need to speak slow also to understand my accent. Okay, so I'll be speaking slow. So shape, size, number of vertebrae, number of nerves are different in cervical spine. Then canal size is also very different. In cervical spine, you have the largest canal size. Then in cervical spine, you have foramen for the vertebral artery. Then in cervical spine, you name it upper cervical spine and lower cervical spine. In lumbar spine, it is only the one lumbar spine. There's no upper or lower lumbar. However, in thoracic, we often use terms upper thoracic, mid thoracic, and lower thoracic. So in this, we are talking about lower cervical spine, not the upper cervical spine, because majority of the time you get lower cervical spine in India at least. And upper cervical spine means only C1 and C2. That is the upper cervical spine. So let me launch very first poll and see what is the confidence level of my attendees in this webinar. How confident are you in lower cervical spine assessment. So here is the question coming on your screen. You just need to say very confident, confident, or not confident. So meanwhile, you give this answer. Let me adjust my camera a little more. Is that fine? No. Okay. So don't worry that there's small cut coming in my camera. That's fine. As far as you are able to see me, at least the camera is static. Okay. So poll is still going on. People are filing the poll. I can see on my computer screen. Poll is closed now. So let me check. It is the 74% says, sorry, it is the 8% people says they are very confident, and 66% says confident, and 26% says not confident. So I have to consider all the three groups. So those who says confident, let's see, and they will probably, it will be more cementing kind of thing for them when I discuss here. So they will, I'm sure they will also learn many things. Those who are saying very confident, I'll try that I share some extra information for them. And those who says not confident, I'll try to start from the scratch so that you people are benefited. Your 1 hour goes well invested. Okay. My next question. What do you think? When does the age-related changes are observed first in lumbar spine, thoracic spine, or cervical spine? Where do you get age-related changes first? In which part of the spine? So here comes the poll on your screen. Let me see what you think. You get age-related changes first in the lumbar spine, or in the thoracic, or the cervical spine, or the upper cervical spine. Okay. So let's see what is your opinion, what is your idea about it. Come on, click it. It's fine. Whatever you think is the right answer, you click that. As you know, I'm going to tell only in terms of percentage. So that's the outcome. Okay, 7% people says it is the upper cervical spine which get age-related changes first. Actually not. Actually, actually it doesn't get age-related changes at all until unless person is suffering from rheumatoid arthritis. C1, C2, because of its anatomy, it doesn't get age-related changes. That's a good news. So anyone call you old, show them your C1, C2. Tell them, abhi to main jawan hu. You are still young. C1, C2. Okay. And then 47 people says lower cervical spine. That's a very good answer, correct answer. And we will discuss why you get in lower cervical spine, why do you get age-related changes first? And you know what age do you get age-related changes in lower cervical spine? What age it started? I read in literature during my PhD time, it is at the age of 25 years. Ji haan, yes. If you are 25 or 26 and you're thinking you are still young, excuse me, sorry, age-related changes already started in cervical spine. Okay, we'll discuss why you get age-related changes at such an early age. At the same time, there are orthopedicians and there are people who claim that age-related changes in cervical spine starts even at the age of 18 years. Okay, and then 4% said thoracic spine, and then 43%, which is a huge percentage, lumbar spine. It is a wrong answer. Thoracic and lumbar spine is a wrong answer. However, 43% people said it is the lumbar spine which get age-related changes first. No. You know, in cervical spine, we have uncovertebral joint. I'll show you where the uncovertebral joint is after asking question, of course, after asking question from you. And because of the presence of the uncovertebral joint, which is not there in thoracic and lumbar spine, because of the anatomy of the facet of the cervical spine, because the so many other factors which I'll be discussing, you get age-related changes in lower cervical spine. However, In the upper cervical spine, there is no disc between C1 and C2. C0 and C1, C1 and C2, there is no disc. And then in addition to that, the facet joint is like flat facet joint, almost flat. So you get a good range of motion also at C1 and C2. How much range of motion we get, we'll discuss that later on. So that is the reason the C1, C2 always escape age-related changes until unless someone is suffering from rheumatoid arthritis. In rheumatoid arthritis, it is C1, C2 do get affected. So you need to be extra careful while examining the upper cervical spine. And if you have been to the Shamshan Ghat, cremation ground, and if you've been to picking the bones after the next day, Phul chunna jise bolte hain. At that day, if you notice, the Pandit will find out one peculiar bone which looks like a man, both arms and the head and the whole body, and he claim it to be the Atmaram of the body. Why I'm saying, I'll tell you why I'm discussing all those things. Atmaram, he claim it to be the Atmaram, the soul. Okay, and then he asks you to pray for that. And you're wondering, my God, the whole body was burning for the whole day and night in such a high temperature, not the femur, not the cuboid, no bone left, and this bone is still there. You know which bone is that? C2. What you see is the dense. It still does not get burnt out. It is such a strong body. Okay, it is such a strong body. C1, the C2. Okay, so this explains how strong the C2 is. There are so many other things. I don't want to discuss the negativity further here, so I won't discuss furthermore about C1 and C2 here. So my next question comes to you. On an average, how many times does a person moves his cervical spine in 1 hour, in 60 minutes? On an average, how many times a person moves his cervical spine? Okay, so the poll coming on your screen now. Let's see. In 1 hour, what do you think, how many times a person moves his cervical spine? We walk 5,000 to 6,000 steps in a day. That's an average steps for walking. But for the cervical spine, how many times? Let's see. Okay, we are getting multiple reply. The percentage is divided among all the categories. Bring it down a little bit for me. Yeah, so 5% says in 1 hour, it's only the 50%, 5% says it is the 50 times in 1 hour, 11% says 100 times, and 13% says 200 times, 12% says 400, 19% says 600, 11% says 800. Highest is 1,000 times, that is 20%, and 9% thinks it is 2,000 times. The correct answer is, as per literature, 600 times. On an average, a person moves 600 times, any direction, in any movement, 600 times on an average, the person moves his neck in 1 hour. Now imagine, uncovertebral joint is there, plus the facet is concave, convex there, and the orientation is oblique towards the eyeball, and then you're moving every 1 hour, you are moving 600 times. Move your knee joint, one of the strongest joint, okay? Elbow, shoulder, hip joint, 600 times. Within 15 to 20 minutes, you will have severe back pain, or the knee pain, or the elbow pain, 600 times. But in cervical spine, 600 times, nothing happens. Such a lovely structure nature has created for us. And that is for 1 hour. Imagine if you are awake for 10 hours, which is much more less than we people are. Like we people are awake at least for 14 to 16 hours a day. Now multiply with the 600 times. Okay, so even if you are, to make it simple, if you are awake only for 10 hours and 600 times, that means 6,000 times in a day you are moving your neck. Okay, so this is what makes cervical spine very, very unique. Next one, let's talk about uncovertebral joint. Maybe some of you, few of you, okay, might have heard this terminology first time, uncovertebral joint. Yes, this joint is available in cervical spine, and you people are wondering where is it? So let's see what the audience think where the uncovertebral joint is. Here's the poll. Okay, let's see. What do you think? This uncovertebral joint are made by articulation of what? Between two spinous process, between two transverse process, or the vertebral body, or the two facet, or the transverse process and vertebral body, then transverse process and spinous process, facet joint and spinous process. I'm sure you people are enjoying this kind of polling, right? Feeling connected, right? You are feeling connected. Yes, you are the part of the real classroom. Okay, so two vertebral bodies. Still the people are answering, so I'll hold it. Okay, so let's see where the answer going. Wait. Let it continue. Let it continue. Wait. For a few seconds. Okay, people answered. Done. Okay, so let's close it and see the result now. Okay, between facet joint and spinous process, 12% people says that's alien anatomy. Okay, and then 7% people says transverse process and spinous process. How is it possible? That's again the alien anatomy. Transverse process and vertebral body, no, not possible. That is 23 people, 23% people. That's good percentage again. And two facet joint, that's a facet already. Facet joint is different. Uncovertebral joints are different. That's the highest percentage. 24% people said facet joint. No, that's the wrong answer actually. Two transverse process 10%, two spinous process 6%, and the right answer is the very first one, between two vertebral bodies, that is 20%. Okay, uncovertebral joints are made between two vertebral body. That means in cervical spine, like you know, in thoracic and lumbar, weight bearing goes through the facet joint and the disc. But in cervical spine, weight transfer is not only through the disc and facet joint, but also through the uncovertebral joint. I have a spinal model luckily with me in this lockdown period, so I'll show you exactly, so it becomes very easy. So I'll request Tanmay to guide me if I'm able to show the correct thing. Okay, so pick the camera and let's see. So can you see this portion? Okay, this portion, this is the uncovertebral joint, the side border of the vertebral body, of the lower vertebral body, and the side border of the upper vertebral body. So exactly I'll pinpoint, this is the uncovertebral joint. That's the uncovertebral joint, and facet joint is somewhere here. Okay, so this is the facet joint, fine, and this is the uncovertebral joint. Stay there. So because there is an uncovertebral joint and you're moving more than 600 times in a day, and you're rotating, you're moving, so slowly, you know, the chondromalacia, the cartilage get break here. There is a cartilage here. Okay, below there is a cartilage, above there is a cartilage. Cartilage to cartilage articulate, fine. And there is a disc here. Then there's an uncovertebral joint here on this side. So you have multiple side, multiple uncovertebral joint. So because of the degenerative changes starts in the uncovertebral joint, you get a lateral fissuring like this, transverse fissuring. And because of this transverse fissuring, the age-related changes starts much more faster in cervical spine as compared to the thoracic and the lumbar joint. One of the reasons why cervical spine get degenerated changes before thoracic and lumbar spine. How do you see those fissuring? If you check the X-ray of even of a young person, AP view, in the center of the disc, you may get. Okay, I need to speak slowly because the video is getting delayed. So I'll hold it for a few seconds before proceed further. Okay, so if you check the AP view of the X-ray, you may see a thin black line in the center of the disc in X-ray or in MRI, in AP view. You know what this line is? This line is that cells are dying slowly and it is releasing the gases. But because from everywhere annulus fibrosis is there, the gas is not able to release. And that's why you see that thin black color line in X-ray or in MRI, that's the lateral fissuring. So that's the reason how cervical spine get age-related changes much faster. So let me adjust the camera again for me. Okay, one, hold it for a few seconds for me. It will hang. No. Is it fine? No, it is tilted now. It's fine. Okay. So we know now where the unconvertible joints are. And we also discussed that C1, C2 often escape from the arthritic changes because of its anatomy and because of the orientation of the facet joint, except in rheumatoid arthritis. We also discussed about the Atmaram, that is the soul after the body is burnt out. This is what you see. And there's a, so, you know, C1, C2 is very different in addition to that. In cervical spine, in any direction, you get 5 to 10 degree range of motion. Only 5 to 10 degree range of motion for fly. Yeah, at each vertebra, at each motion segment. But at C1, C2, especially the rotation, is very different than the lower cervical spine. Do you have any idea how much rotation you get between C1 and C2? Let's check that. Next poll coming up on your screen. Let's see what you think. The rotation between C1 and C2. Okay. Okay, people are voting. Let's see. This time I'm getting lovely results. I'm so happy to see those results. Excellent. Still people are answering. Okay. So the correct answer is 40 to 45 degree. And this is what the majority of the people have answered. 43 people. Look at the coincidence, okay? 43% people have answered the range of motion at C1, C2 on one side. That is one side rotation, okay? One side rotation is 40 to 45 degree. 20% said 2 to 4 degree, 22% said 8 to 10 degree, and 15% said 85 to 90 degree. Okay, so now you know total you rotate 90 degree in one direction, okay, 90 degree. And 50% of this 90 degree, that is 45%, comes exclusively at C1, C2. And the lower cervical spine altogether comes at 45 degree. And that is why many times patient, when they come to the clinic, they don't complain, much complain as ADL, when you get the ADL field. Rotational activities are not much affected because they are still able to manage from C1, C2, which do not get aging. Lower cervical spine, even if the rotation is restricted, they are able to manage the rotation. But flexion extension, which is very minimal at C01 and C1, C2, and it is more at the lower cervical. Flexion extension at the side flexion. So people do complain more about flexion, extension, side flexion, and rotation in the lower cervical spine. And you know which segment in cervical spine get affected first? It is the C6, 7, and T1. You know why? Because after proper mobility, sudden immobility comes. T1, T2, T3 doesn't move much. So that is the hinge actually. You get more movement, more wear and tear at C7, T1 and C6, 7 and sometimes 5, 6 also. And always remember, it is the hypomobile spine will have more pain. Same green stick example. If there is a dry stick and you bend it, it will break. But if it is a flexible green stick, you can move it, it won't get break. So very simple. Mobility is important for sure. So now you know that even at the age of 25, you are old at lower cervical spine, and even at the age of 80 years, you are young at upper cervical spine. So when the patient comes to you, let's start that discussion. Let's start the examination part of lower cervical spine. So now that was the orientation of the cervical spine. Okay, few facts about the cervical spine, how it is different from the lower cervical spine. So when patient comes to you, obviously you ask name of the patient, age of the patient. All clinical correlation we'll be discussing after we discuss the combined movement assessment, we discuss the how to examine patient, and then how to correlate all those things. We'll be discussing that. Okay, so right now I'm just telling you that you need to ask all those things, and then later on how to correlate, so that you reach out a proper diagnosis at the end of the session. Okay, so stay till last. Fine. So first of all, you're going to ask the name of the person, age of the person, gender you need not ask, you know, by looking at the patient. And then you ask the occupation of the person. Maybe, you know, he's a dry cleaner and all the time he's hanging the things, or maybe he's a sweeper and all the time neck is down. So knowing profession again for the spine is very, very important. And then you ask the chief complaint of the patient in a chronological order in his own language. Sometimes patient comes and, you know, the chief complaint they have, I have a disc bulge. You know why? Because he got the MRI done already, and he read the report and Googled it. Googla ke aate hain sare patient jata. So if you go to my webinar, which I took on last time on 26th, I believe. Not 26th. 25th of April, I took a webinar on MRI, how to read MRI. Its recording is there on my YouTube channel, Deepak Kumar Capri. So you can read that and you'll know when to consider disc bulge or when to not consider disc bulge. Anyway, back to topic. So patient comes, take the chief complaint in patient's own language. Where is the pain? How it started? When it started? Was it there before also? Rather patient saying, I have a disc bulge. ये disc है, disc. ये disc नहीं आसान, दर्द का दरिया है और short wave लगवाना है. No, that's not the chief complaint. Okay. So, and patient will force you to go through the report first, rather than saying that you listen to me. They say, I have a prescription, please go through this. This is the treatment I want. Then you'll end up in the same diagnosis. Okay, please don't see that film. Please don't see that report. Please don't see that prescription. Put it upside down. Tell the patient, okay, don't worry, I'm going to see. Let me ask few questions first. It's not that I'm going to ignore those findings. I'm going to see. Assure the patient that you will see that. Okay, then you check the chief complaint of the patient in his own language, in chronological order. Then check what increases pain, what decreases pain, when diurnal variation of the pain. When does he get more pain? In the morning, afternoon, or the evening, or the night? If it is night pain, it is going to be something very serious. Okay, so go for detailed investigation in those cases. Anyway, morning pain, afternoon pain, evening pain. If morning pain, how long does the pain stay? If it is localized pain or a radiating pain. If it is radiating pain, check which dermatome, myotome is involved. Then check the movement. Which movement in patient's own language? You are still not examining. You are only taking the history. What movement increase your pain? What movement decrease your pain? Which activity increase your pain? Which activity decrease your pain? Get the ADL, neck disability index filled, and you will get much more clear ideas. ADLs are very useful tools for physiotherapeutic examination, and each physiotherapist must get it filled for any joint they are examining. Okay, after getting those all history, which will be correlating later, you go for the examination, postural examination. Now you start the observation part, posture examination. And you know, people say they know posture examination. Sometimes I smile on that. You know how many types of posture recorded in literature? How many types? I'm not launching a poll now, but you can count any number, whatever number you want to count. Whatever number you counted or whatever number you said, let me give. Okay, so the answer is 327 million combination of the posture. 327 million. Could you believe this? And people say they know postural examination. Congratulations if you know it. Lovely. So people think they know the postural examination. Right now, I'll not be discussing the whole body, but I'll be discussing only related to the cervical spine. So you are going to examine patient with the same eye level from the front, from the side, from the left side and the right side, and from the behind. And then you are going to compare. If you are able to see something from the left side, but you're not able to see something from the same thing from the right side, cancel it. It's not valid. You need not pick that. You are able to see something from behind, but not able to verify it from the front, cancel it. No need to record it. Okay, you should be able to see it from the front, back, sideways, side. So what do you see from the first thing? You stand behind the patient. And when you come, I'll request Tanmay to again come and help me. And when you do this thing, when you do the postural examination, one more poll, okay? One more poll. When you do this postural examination, do you ask your patient to keep his eyes open or closed? I'm talking about the eyes of the patient, not the eyes of the therapist, of course. Okay, not therapist eyes, patient eyes. Patient should keep his eyes closed or open while you are doing the postural examination. Let me see. Let them answer. Okay. The 7% people says it doesn't matter. Actually, it matters. Okay, and the 55% people says eyes open, which is a wrong answer. The right answer is 37% people said eyes should be closed. Of course, if the person is having some vertigo issue or some balancing problem, okay, no problem. In between, he can open the eyes. But I want you people to examine your patient with the eyes closed. Patient should close his eyes. Why? Because, okay, watch me now. So what you're going to ask patient, close your eyes, and after closing your eyes, move your neck in multiple direction and hold it in a place where you think is the neutral position for you. So you are checking the posture now, what his cerebellum believe. I'm closing my eyes and this is my posture. Now I do not know whether my head is straight or rotated or tilted or what. Fine. So that's the actually my real posture. Unconsciously, I'm always maintaining. Okay. But if you ask the patient to keep his eyes open, because you are examining, he'll maintain his best possible posture in front of you. And you may be misleading, misguided. As I said again, if the patient is having balancing problem or something, you may give some support to the patient so that patient do not fall and allow patient to open his eyes in between. But if balancing problem or vertigo problem is not there, patient should keep his eyes closed. So see now, that's what I said. Many people probably thought they know the postural examination. It's different. I'm talking about different things now. So very first thing you're going to examine from the first, and if the neck is absolutely straight, and before I start, I request Tanmay to come and help me for holding the camera, because now camera will be moving. And you'll notice probably when the camera is moving fast, you may get video little jazzy, but then my hand is getting jazzy right now. So, but when we'll start demonstrating the things only when the camera becomes stable. So your view is not obstructed. Okay, so request from Tanmay, remove the camera now. Let's go charging the. Okay. So you need to check. Fine. So you need to check if the neck is absolutely straight or not. You should be able to see both the ears. Okay, look at the eyebrow level. Don't see the eyebrow, check the bone. Because many times people goes to the saloon or to the beauty parlor and the level might be up and down. So look for the eyebrow level. Look for always check for the bony areas, okay? And then the nose, sorry. Is that okay? Okay, so check for the ear. check for the eyebrow, check for the nose, check for the bony prominence, okay, orbit above and the orbit below and the level. And then you draw a straight line that should go through the center of your sternum, Ziphis sternum. And if this straight line is falling away, that means, and you have to also understand, maybe it is not the side flexion. Very often, clinicians forget to examine or check the translation. There is a difference between a side flexion, that is a rotation around the sagittal axis, okay? However, translation is a transverse movement, okay? So there's a difference between translation and the rotation. This is a rotation around the sagittal axis. Obviously, the treatment and the glide and the manual therapy is different for both. So you should be in a good position to make out difference between the translation and the rotation. So if it is a translation, the line going straight and line going there will be parallel to each other, okay? But if it is a side flexion, now the line will cross each other. Can you imagine? The line is crossing each other. Okay. So when you do this, the line is going cross like that and line going cross like that. So in side flexion, it will cross, but in translation, it will be all parallel to each other. Fine. Next one is the rotation. In rotation, if the neck is going like that, again, the straight line will go out of it. But then you see more of a ear, more of the face on this side. Fine. So you have to see whether it's a rotation, it's a translation, or the side flexion. Now, remember one more thing. Patient has a right to be complicated. Patient has a right to be complicated. Now imagine. So patient is having translation and the rotation. And now the line is going straight still. So you again have to see so many things. And the same thing you are going to see from behind, the ear level, the top of the ear, the bottom of the ear, and you draw a straight line going from the C1, C2, and the center of the occiput, and then the straight line going up. Then from the side you have to examine, check the angle between your occiput and the C1, C2. If it is protruded neck, obviously the angle will be small. And when this angle is reduced, the fascia will be tight. And if the fascia is tight, the greater occipital nerve will get compressed. And patient will complain of cervicogenic headache. He will say whenever they get up in the morning, they often get up with the headache, and the headache starts from behind, and with the neck movement, the headache increases. So think of the C1, C2 rotation at that time, which is not a part of this webinar, but you should be aware of that. So check for this posture, check for this, and not only this, forward, you may say, okay, this is a forward translated head, but along with forward translated, check for the flexion and extension also at C1, C2 again. So this line of my glass, the line, if you draw a line from the end of the eyes and the top of the ear, it should be straight, parallel to the floor. If it is going slightly up, it's a extension going up, and if it is down, it is a flexion. So depending what is your finding in posture, and you are going to examine patient accordingly. You're going to plan out your treatment accordingly. You're going to stretch or strengthen the structures accordingly. You should be able to find out the difference between a rotation and the translation and the side flexion at different plane, at different axis. So this is only about the cervical spine posture I'm talking about. Next one, we talk about the active range of motion of the cervical spine. Now, active range of motion, people say, okay, bend neck forward or backward, forward, back. No, that's not the one. I'm talking about segmental examination. Means you should be, being a good clinician, you should be able to see each vertebra moving. Segmental examination I'm talking about. And keep communicating with the patient. Talk to the patient. Suppose if the patient is having problem at C4-5, so when the patient moves this, patient should not complain pain. Now also, and now it is a turn to move C4-5. And moment C4-5 is moving, because you are communicating with the patient, patient should say, yeah, now the pain started. So when patient says, now the pain is started, you should check which vertebra moving at that particular time. Okay, So segmental range of motion you're going to do. So I'll borrow my model for that. Okay, so the patient stands straight. Thank you for wearing mask during this coronavirus lockdown time. So you need to see the movement between occiput C1 and C2. Okay, so I'll show you the exclusive movement at C1, C2. Now protrude your neck and retract. Can you appreciate? Just don't do that much movement. Okay, that's it. So can you appreciate the movement exclusively flexion extension coming at C1, C2? Now hold there and then ask patient to bend neck forward slowly. And when the patient is bending neck, can you appreciate the movement there? Can you see? Now the T1 moving directly. Sorry, C7 moving.
Wait,
now,
wait. Let me please adjust the camera.
Okay.
Yes.
Do it again. Straight. Do the chin tuck. And not chin tuck, just stay there and go slowly and watch this area moving. I didn't notice much movement at C3 level, okay? So you go down and even at C5 level, not much movement, directly jumping at C6, 7. So I can notice there's not much movement at C5 level and then come back slowly. Let's do it again. Do it slowly, do the chin tuck and then go slowly and see not much movement coming at this segment, movement jumping directly there and a little bit there. And if the patient is complaining pain in this segment, I'll put it as hypomobile spine. Same way, I'll go for the extension, which is difficult to see through the camera, okay? But I'll show you the side flexion now. Let's see if you can pick side flexion through the camera or not. Yeah, side flexion is good, quite good. We are having smooth curve throughout the spine and then bend on this side, then look at the side curve throughout the spine and then ask person to rotate and then check the range of motion at each segment. You should be able to check. I'm not sure how much you are able to appreciate through the camera, but you can see each vertebra moving if you concentrate very well and look at the skin folds, how the skin is moving. Patient need to move slowly. So you check the active range and then you palpate the active range. In case you are not able to see, then you feel it. So I'll put my fingers there, okay? And then again, ask my patient to move it slowly. Yes. And what I said earlier, I was right. There is no movement between C5 at C5. C5 moving very minimal. However, there's a good movement at C3, 4 and C6, 7. C5 not moving. Okay, so you palpate the range of motion. Fine. So you check the active range of motion at C1 at cervical spine and correlate and talk to the patient about the pain. So how much is the pain there? And then you palpate the active range of motion. Now, for the shoulder, for the elbow, and for the shoulder. So for the shoulder, for elbow, for the knee joint, when patient comes, you examine active range of motion and passive range of motion. Why not for the spine? Spine also, you need to examine active range of motion as well as passive range of motion and palpate it. Because when you do passive range of motion, you rule out the muscles, okay? You do it passively, slowly, and gently. Though there's a limitation, but we'll try our level best to show passive range of motion and its palpation for the cervical spine. So let's do it. Lie down spine on your back. Move up. Come towards me. Move. Yeah. Okay. So patient is off the table. Okay. Head is off the table. And you're holding the head like you're holding the coconut. Okay. The dab filled with some CSF or the fluid here. Okay. And patient should be totally relaxed. And you're holding it like that. One hand is free. So you can palpate with this hand. Or you can do with any hand. You can hold it there. Sorry about my thigh. It goes there. And now relax. So this hand is supporting it. And the other finger goes behind the spinous process. And just be relaxed. And then you do small oscillatory movement and try to appreciate the movement at cervical spine. And as you go up and up, up and up, up and up, you get the spine. Okay. And then you check the side flexion or the side flexion on the opposite side, but then you can also hold it from here and check for the side flexion. For rotation, I'll prefer to keep my hand on the facet joint here. Okay, just be relaxed. And then you rotate it and try to appreciate each vertebra moving there. Okay, so you check the flexion, you check the extension, you check the side flexion, and then you check the rotation. Right.
Okay. So next thing is, after checking posture, first of all, you have taken the history. Name, age, gender, what happened, when happened, how happened, what increases pain, what decreases pain, what movement is painful, what movement is pain relieving, diurnal variation, daytime pain, nighttime pain, morning pain, evening pain, and then you're checking the posture, then you're checking the active range of motion, you're palpating the active range of motion, then the passive range of motion, you're palpating the passive range of motion, and now the accessory lines. Okay, so you check the each vertebra, where how much joint play is there, and then you reconfirm whether it is a hypomobile or hypermobile. So you'll be doing multiple glides for flexion or for extension or for side flexion or for rotation. Okay, so you'll be doing, I'll not be doing PA or AP glide, okay, because we don't believe in PA or AP glide. Facet joint orientation is like this, okay, like this. If you do pure PA, it will jam it. No, I won't push it in that direction. I'm going to push it obliquely towards the eye wall so that it moves. It's a natural movement, okay? It's a natural apophyseal movement I'm trying to do to assess so that it does not produce pain. And while doing this palpation also, it should not. Remember, all this maneuver must be painful. It should not provoke pain. It has to be done gently and slow. So now I'll do the palpation. And before I go for palpation, let's see what do you think, which spinous process you palpate first, starting from the occiput. So you'll get the poll now again, and you have to answer which spinous process you palpate first when you go from occiput downwards. No, I need to Yep, you're on.
Okay, the 40% people said C2. Very good answer. The very first spinous process you palpate is the C2. Okay, not the C3, not the C4, not the C7. Probably those who answered C7, probably they are thinking I'm talking about the most palpable spinous process. No, that was not the question. Question was the first palpable spinous process. Why you are not able to palpate C1? Because there is no spinous process at C1. Okay, so the first spinous process you palpate is C2. Let's do the palpation now. It's already 1 hour.
Yes.
Okay, so it's already 1 hour. I have to go very fast now. So first spinous process, you get the C2 and then C3, 4, 5. So I'm increasing my speed so I can complete my topic. And then you check the glide, okay? Check for the flexion. Now, if you notice, I'm not pushing with the pulp, I'm pushing with the medial side of the thumb. And then I'm pushing it from here. That's for the side flexion. Checking for the side flexion, okay? For checking the rotation, I put my thumb on either side of the spinous process and then go for the transverse glide. And again, I'm going to check whether that is provoking pain or not provoking pain. Fine. So after the palpation, after doing the active range of motion, passive range of motion, accessory glides, what I'm going to do is the checking the combined movement pattern. Why we need to check combined movement pattern? Because remember, many times patient comes and you check the range of motion. Actually, sometimes you may provoke pain. While doing the assessment, you may not be able to provoke pain. When you're not able to provoke pain, you may consider this as a
people are saying that the accessory part was very high. And they're saying that it's okay, you can extend time, they're thirsty for the knowledge.
They can extend for the, okay. Don't worry, still it will take almost another 1 hour, okay. So after completing this, if you people want, I'll demonstrate the accessory glides once again. Don't worry. And let me complete the topic first, and then I'll come back and demonstrate the accessory part once again. Because still a lot more left in this examination. So when you are not able to provoke pain, the clinician thinks it's a psychological one. You know why you are not able to provoke pain? Probably you are not able to compress or stretch the structure. Remember one thing. 2 laws I teach to my students. And I know there are 2 or 3 people are commenting that it is not reliable method of examination, it is not evidence-based practice. To those people, I already said I'm not talking about evidence-based practice. I'm talking about evidence-based practice. I'm talking about practice-based evidence. And I do not know why they already know I'm doing practice-based evidence. Still, in every webinar, they come and invest their time. I don't know why. Why? So please, if you want to listen to me, listen to me. You think I'm not making sense? I don't know why you're coming in every webinar. Anyway, those people probably already left after commenting. That's fine. This is what I came to know. Anyway, so I'm talking about practice-based evidence here again. So 2 law I always teach to my students, like 1/2 law for the heat. Any chemical reaction capable of getting accelerated will get accelerated because of heat. So here, any neuromusculoskeletal pain, any neuromusculoskeletal pain, if can be provoked, will get provoked either by maximum compression or by maximum stretch. Any neuromusculoskeletal pain, if can be provoked, will get provoked either by maximum compression or by maximum stretch. And if you notice, all orthopedic tests are designed on this formula. I don't know, but nobody has documented. So I call it law 1, law of pain 1. Second law, I say, this I'm not talking about somatic pain, okay? Not the visceral pain I'm talking about. I'm talking about neuromusculoskeletal pain. I say pain can travel front to back and back to front, but not from left to right and right to left. Pain can travel front to back and back to front, but not from left to right and right to left. That means if the femoral nerve is getting compressed, where do you get pain? In the front of the thigh, traveling from back to front. Okay. If the anterior part of the disc get injured, where do you get pain? In the back of the thigh because of the sciatic nerve involvement, back to front. But if the nerve is getting compressed on the right side, you get pain on the right side, not on the left side. Okay. So pain can travel front to back and back to front, not from left to right and right to left. These 2 laws you have to remember. And now I'm going to show you how to maximally compress and maximally stretch the structure to get the pain. I'm not talking about our pain, I'm talking about the pain, the one which patient was complaining of. So let's talk about a little bit of, just very fast, little bit of biomechanics. So when you bend forward, so what happened? You get the stretching here, right? And you get the compression here. And when you go for extension, you get stretching there and you get compression there. When you go for side flexion, you get stretching there and you get compression here. When you do side flexion on this side, you get compression here and the stretching here, right? No doubt about it. Now divide whole body into 4. Pure sagittal, pure coronal. So this become left anterior and this become right anterior. This become left posterior and this become right posterior. Okay, clear? Left anterior, right anterior, left posterior, right posterior. So now, if I am doing this flexion, what is happening here? Obviously, the compression. This side, compression. This side is stretching. This side, again, stretching. Now, without losing this range of motion, I'm going for side flexion without losing flexion. So this side get more compression, okay? And this side was earlier compressed, now stretched. So this is neutral. Don't say less neutral, less compression or stretching. For example, I give you $10 and then I take back $10. So do you have less $10? No, you have zero, sifar, Babaji ka tullu. Okay, so you don't have. So this becomes a neutral one. Okay, so this is neutral now. Let's start it again. So when you bend forward, compression, compression, stretching, stretching. And when you do this, you get more compression. This is neutral. This is more stretching. And this is again neutral because you stretched it and then you compress. Clear? So I'll call it left anterior compression pattern if the patient is complaining pain on the left side. I told you pain cannot travel from left to right and right to left. Because you may call it right posterior stretch also. But only when patient is complaining pain on the right side. If the patient is complaining pain on the left side, it is a left anterior compression. Okay? And if the patient was complaining pain on the right side, I would have called it right posterior stretch pattern. These two are anyway neutral. In neutral, you won't get pain. Any neuromusculoskeletal pain, if get provoked, will get provoked either by maximum compression or by maximum stretch. Fine. Let's take a few more examples. So this time, now the patient is having pain again on the left side. And it is this movement gives pain to the patient. What do you think? What is getting maximum stretch? This area getting maximum stretch. So I'll call it left anterior stretch pattern. I'll not call it right posterior compression. I would have called right posterior compression if the pain was on the right side. And if the patient complains pain on this way and complaining pain on the right side, so I'll call it right anterior compression pattern. Another patient comes and if he's complaining pain on this side only, right side only, and this movement is giving pain, so I'll call it right anterior stretch pattern. So you are maximally compressing or maximally stretching the structures. Fine. And then you are asking the patient, are you getting the pain, the same pain, what you are complaining of? Because now you are compressing those structures. Fine. Just two more examples, then I'll ask the question whether you have got the answer or not. Okay, now the patient is complaining pain on the right side. Okay, so extension gives pain and left side flexion gives more pain. What do you think? What is the pattern? If you people said left posterior compression pattern, you were right. Another example, patient is having pain on the right side and it is the extension and right side compression giving pain, right side flexion giving pain. So what do you think? It is a right posterior compression pattern. Absolutely right. So that means the pain is getting provoked because of the compression of the structures here. Or if this is the pattern and patient is complaining pain on this side, that means it is those structures which are getting stretched and you are complaining pain. People want me to speak slowly. Okay, so thanks to my team, they are giving me the feedback if I'm going too fast. Okay, so this is the pattern and this is getting stretched. So I'll call it right posterior stretch pattern. Fine. Now let me give you a task and ask what is this pattern is. First, I'll show you the pattern on my body. Okay, and then you will get the poll and let's see how many of you give right answer. So the patient is complaining pain on the left side. Left side, patient is complaining pain on the left side. And is the flexion and left side flexion giving pain. What do you think? What is the name of pattern should be? Poll comes on your screen. What do you think? What is the pattern? Patient is having pain in flexion and left side flexion. Pain is on the left side. Wow, I'm so happy. Wow, I love you all.
Great.
Four.
74% people are right. They said left anterior compression pattern. Yes, because pain is on the left side, okay, and it is the flexion giving pain, and left side flexion giving more pain. 74% people are right. Thank you. This is, I'm teaching you now the theory of Brian Edwards. Unfortunately, he's no more with us. Brian Edwards' combined movement theory, you can find it in his book. It's available on Amazon. You can buy that book, Combined Movement by Brian Edwards. Though we have modified it a bit as per our clinical practice. So, but anyway, I'm teaching you based on his concept. Brian Edwards, Combined Movement theory. Now the next example, okay? So, but are they able to see my face also?
Yes, they are able to see your face.
Okay. So now the patient comes with the pain again on the left side. Pain is on the left side, okay? And it is the extension giving pain. And then the right side flexion giving more pain to the patient on the right side. On the left side. So it is the extension and right side flexion giving more pain to the patient. What do you? Okay, sorry. Let me put it properly. Probably left right ka I have done some mistake. Okay, pain is on the left side. Okay, pain is on the left side. It is the extension giving pain, and right side flexion giving more pain on the left side. What is the pattern? Here is the pole. Pain on the left side, extension, and right side flexion giving more pain. I'm so happy many people are getting the right answer, right result. How slowly it is getting changed. It is going like das kadam, the graph is going up and down. Okay. Okay. Fine. Though the majority of people have given the right answer, 43%, but this time the percent has gone down. It is 43%, which says left anterior stretch pattern, which is the right answer. Other next group is 30%, which says left posterior stretch pattern. See now, how can it be left posterior stretch pattern? Watch me again. I'm doing this. So left side is getting compressed, right? And then I'm doing this. So before it is getting compressed, now it is getting stretched. So it is neutral, 0. If I would have done this, now the left is getting stretched, and then this is getting stretched. Now I would have called it left posterior stretch. But when I'm doing this area getting stretched. And when I'm doing this is getting more stretched. So this is going into neutral. Stretch, compress, compress. Neutral, maximum compression, maximum stretch. Maximum compression I'm not picking because pain is not on right side, pain is on the left side. Okay, let's go for the next example. Now the patient is having pain on the right side. Okay, right side pain. And it is the flexion and left side flexion giving more pain to the patient. Let's see, what is the example? What is the answer? Pain on the right side, flexion giving pain. So compression, stretch, and then left side flexion. Okay, so what is the pattern? Pole is coming there. Very good. Again, this time the percentage is going quite good. Wait. People are answering. Okay, we'll hold it. I'm so happy that majority of you are answering. Good one. Okay, so this time 50% people said right posterior stretch pattern, which is a right answer. Right posterior stretch pattern. We're going for flexion, stretch, compression, and this is a stretch. Okay, Now this is neutral, this is compression. Now I'm not going to call it left anterior compression because pain is on the right side. Pain can travel front to back and back to front, not from left to right and right to left. And any neuromusculoskeletal pain, if can be provoked, will get provoked either by maximum compression or by maximum stretch, not in neutral. Okay, fine. One more example. Pain is on the right side. Okay, and it is the extension and right side flexion gives pain. Pain is on the right side. Extension, right side flexion gives pain. Tell me, what is the pattern? Fast. This time need to be very fast. Come on, reply fast. I love you all. It's going very high percentage towards. And you know, those who know the answer, they're answering khadak like that. And those who are taking a lot of time, they're only giving the wrong answer. Those who are answering immediately, their answer is usually the right answer. They are on the right click. Yes, it is a right posterior compression pattern. And this time it is 68% people answered rightly. Two more examples I will give, and then I'll proceed to the next topic. Next, this time, the pain is on the left side. Okay, pain is on left side. It is the extension and left side flexion giving pain. Tell me the pattern. Extension, left side flexion, giving pain to the left side. Hole is there. Tell me. Beautiful. People are answering immediately. Click it, stop it now. And the phone. Majority of them have answered. Okay, so it is a left posterior compression pattern. You are right. Okay. Now the last example, and then we move to the next topic. Now the patient is having again pain on the left side. Now you people are getting it. I'm so happy. And majority of the population are giving right answer. It is pain on the left side. Fine. Pain on the left side. Flexion, right side flexion giving pain. Tell me the pattern. Flexion, right side flexion giving pain. Tell me the pattern. Pain on the left side. Good. Majority of the people have answered. That is left posterior stretch pattern. That's the right answer. Okay, left posterior stretch pattern. Now, next topic. How do you decide which structures are involved? What structures involved now? Now, remember, if it is the muscle which is involved, if it is the muscle which is involved, so when you move this way, it will give pain, and while coming also, it will give pain. So while doing this combined movement, if patient complains pain locally, not radiating one. If it is a radiating one, probably the nucleus pulposus moving in that direction. So person will have radiating pain. But if person is complaining localized pain could be ligament, could be facet, could be muscle. I'll not consider it facet because I'm opening and facet is opening. So if facet is opening, why facet should give pain? Okay. So, and if the patient is having localized pain, not the radiating pain, it is probably not the disc also. So you check the pain, whether it is going as well as coming, both are giving pain, or only it is the end range. If it is end range, it is the ligament which is going to cause pain. But while going and coming giving pain, it is the muscle. Fine. So while doing this combined movement, and patient is having right posterior stretch pattern, and while going and coming, it is giving pain, I'll put it as muscle strain. But if the patient is complaining pain in the end range, I'll put it as a ligament sprain. Fine. And if while doing this movement, patient get a radiating pain, I'll put it as a disc prolapse. Fine. So radiating pain, disc prolapse. Going and coming giving pain, muscle. End range giving pain, ligament. Okay. Now imagine if it is a compression pattern, right posterior compression pattern. And again, you have to see whether it is a localized pain or a radiating pain. So
In this position, muscles are relaxed, ligaments are relaxed, capsules are relaxed. They should not give pain. What is getting compressed is the facet joint. So if patient is complaining pain, probably it is the facet joint. If it is a localized pain, but if it is a radiating pain, it could be foramen or it could be extrusion. Foramen, I'll consider if my patient is an old age patient. But in young age, you don't expect stenosis, so I'll expect extrusion. So if it is a radiating pain in young patient, it is extrusion, and if it is a radiating pain in this position in old patient, foramenal stenosis. But if it is a localized pain, I'll put it as a facet joint. So in 1 minute, I'll repeat. So if it is a posterior stretch and going and coming giving pain, muscle, end range giving pain, ligament, radiating pain, protrusion, fine. Young patient or old patient, localized pain, facet joint arthropathy. Radiating pain, foramenal stenosis. Radiating pain, but young patient, extrusion, because part of the disc is already out. When you do this, nucleus pulposus doesn't go back. It comes more out. So it is extrusion. So after knowing the aim, name, age, gender, what happened, when happened, how happened, what increases problem, what decreases problem, which segment is affected, which side is affected, which segment is hypo, which segment is hyper, which dermatome, which myotome, you know the segment now. You know the vertebra. And after vertebra, you know the type of injury, whether it is a compression pattern or a stretch pattern. After knowing that compression or stretch pattern, you also check what structure involved, whether the ligament or the disc or the extrusion or the facet or the foramen. And then you come out with the diagnosis. At C5, 6, you have facet joint arthropathy. And then patient get the MRI done, and in MRI also it gets the same answer. That is how a physiotherapist should diagnose all the mechanical pains. Or you may diagnose, okay, it is a muscle strain at C4-5. Or it is a ligament sprain. Or it is a extrusion at C4-5 or C6-7. Or it is a foramenal stenosis at C7-T1. So now you correlate everything and then you make a diagnosis. This is how the diagnosis of a cervical spine should be made. I would have covered neurodynamics also, but probably I'll take another webinar for neurodynamics and the treatment part of it. But this is how you diagnose. And in the beginning, I promised you that if you attend this webinar till the last, probably you will not need MRI. Only for pathological condition you will need, but for mechanical pain you will not need MRI, and you can examine, you can diagnose patient as accurately as possible. So when you know it is muscle, your treatment will be for the muscle, not for the disc. When you see it is ligament or the facet or the foramen, accordingly you will plan out your treatment. Okay, not just seeing the disc in the MRI and start treating the disc. It may not be disc, it might be something else.
I don't think we will be able to take up all the questions, but we'll try our best to take up a few. And for the rest of them, you know, sir is totally accessible by email and by other means like his Facebook page and his website. We can type in your questions, and sir will be more than ready to help you out. Are you with us now, sir?
Yes, I'm there. I can hear you loud and clear. Yeah.
Okay, sir. So initially, sir, I was just trying to tell you that you don't need to worry about the time at all. I think you did well. So not at all. I don't think anybody minded.
You know, I get emotional and I always want to share as much as possible. And if people are spending the time, it should be wisely invested. So I love sharing my knowledge, whatever little bit I have with my participants. Always love that.
Thank you so much, sir. So starting with the questions, sir, there were a number of questions. A few of them we have picked out. The first one I would like to ask on the behalf of our participants is that what are the basic red flags that we should be looking for when we are dealing with the cervical spine?
All the red flags, not only not specific to the cervical spine. There are red flags like you need to check the osteoporosis, you need to check the tumor, you need to check if the patient is on anticoagulant therapy, if the patient is pregnant. Pregnancy does not mean only sacroiliac joint or lower cervical. Okay, and then you need to check if the patient is having aortic aneurysm. So many, all the manual therapy contraindications are there. If they want to go in detail, I won't take much time. but on my YouTube, I have already mentioned list of all the red flags. They can go, and I have put a very elaborated videos and explained how to check all those red flags, also how to examine those red flags, what signs and symptoms they will get. So they can go and check that. There are a list of red flags they should go, and that is valid for the cervical spine also.
Another question which people have been asking is regarding the black line you said you see on the x-rays in the disc. So what are these gases and how are they released? Some more elaborate on that, please.
I have no idea what those gases are. Okay, this is what I read. And when the cell dies, cell release certain gases. Unfortunately, cell is not as lucky as we people are. We release our gas, cell is not able to release that because it is well intact from all around. The gas got trapped in between. What gas it is, I don't remember. Whenever cell dies, some gas get released. So that should have been the gas. I do not know whether it is nitrogen or what gas it is, or bicarbonate or whatever. I have no idea, sorry. So probably they need to go for more literature review and check it out, which gas it is. I think they want to know which gas it is, right?
Yeah, many people are asking same question.
No, could have been, I think maybe the nitrogen.
Yes, I also think it is nitrogen oxide because that is usually the gas which is released when the cell apoptosis.
Yeah, okay.
And it decomposes.
So the next question, there were a lot of questions on uncovertible joints. So I have picked up one out of those. So what is the reason why uncovertible joints have more changes in them?
Because it is rubbing all the time and it is a weight bearing joint. Okay. And it is a lot of rotation you do all the time. And it is very close to each other. And then it is a very small joint. The surface area is also very less. That could be the possible reason that uncovertible joint get affected first, because if the surface area is less and you put a needle and you push it only with 1 Newton force, it will go through. But if you put your hand and push with 10 Newton force, it will not go through. Okay, so facet joint is quite large, but uncovertible joint is relatively much smaller and the weight bearing is quite high. So could be the reason that it get degenerative changes faster.
People were quite happy with checking your combined movement testing, and many of them got it also, as we could see in the polls, but still people have many doubts. Like these combined movements first, should they always be checked actively only, or they can be checked passively only? Will there be any difference?
It should be done active assisted. Patient should be doing it actively. As I said, pain is your friend, not your enemy. Okay, make sure you assess patient in such a way that you don't provoke pain. Okay, like one of the example, in frozen shoulder, patient comes to our clinic with stiff shoulder. That is what the chief complaint of the patient is. And when he go out of the clinic after first visit, his chief complaint is painful stiff shoulder. He comes with the stiff shoulder and goes back with the painful stiff shoulder. So I don't want that. So I want it to be the active, guided by the therapist, assisted by the therapist. So you don't push it into that painful direction. Okay, so it's a safe practice. So you don't provoke pain too much and keep talking to the patient. Okay, at the onset of P1, you add the secondary movement. First of all, you check the movement. Patient says, yeah, pain comes. And then you add the secondary and patient says, yeah, pain is increasing or decreasing. If it is increasing, means it is a compression pattern. If it is decreasing, that means it was a stretch pattern which is getting relieved. So it is decreasing. So while doing this, you should be communicating with the patient and you can make out which pattern it's going to be.
Another question on this is, if the pain is centralized or there on the both sides, then also our combined movement examination is helpful?
Yes, it is helpful. And in that case, what I'll do, I'll pick the sin, severity, irritability, and nature of pain. Okay. So 1 second, it's going on. Okay. So in that case, I'll pick the severity first. Suppose if I get a compression pattern at this range, okay, which is quite end range, and the compression pattern on right side for this range, which is less range, I'll treat right side first. Okay, but it is useful. So I'll pick the first one, which is more severe. How easily it is irritable.
I think we follow the same rule otherwise also, that the joint which is more irritable is dealt with first and then the other ones later on.
Absolutely.
So there were a lot of questions on cervicogenic headache on the panel there, but I am sure we did not deal with the upper cervical spine.
Upper cervical.
Yeah.
Maybe in some other webinar we'll
Maybe
deal
some
with
other
the
webinar, yes.
upper cervical spine.
Yes, sir. But sir, if you could just throw a little bit light on the forward head posture there. Just very, very briefly.
Okay. Okay. So when the patient comes for the cervicogenic headache, you know, when the patient comes to you, majority of the time they will say they have migraine. They won't probably admit they have cervicogenic headache. So do the take the history properly. Okay. Just 1 second. Yeah.
Yes.
Hold it properly, please. Yeah. So take the history. In cervicogenic headache, patient complain pain coming from behind. In migraine, it will come from the front. Both could be half side. Both are associated with vertigo and nauseating feeling. But patient with the migraine, they will say they have a different aggravating factor. Okay, aggravating factor could be light, sound, food, caffeine product, you know, mental stress, all those things are aggravating factor. However, in cervicogenic headache, it is the neck movement which is the aggravating factor. And there is a specific test for checking whether it is cervicogenic headache or not. In supine lying, we check the rotation exclusively at C1, C2. I told you it is 45 degrees. So if it is reduced, restricted, it is a cervicogenic headache. Plus cervicogenic headache patient will also say they get pain in the morning as well as the migraine patient. But migraine patient may say that he had an aura day before. He knew that tomorrow he's going to have cervicogenic, he's going to have migraine. But cervicogenic headache patient will not get aura. Rather, cervicogenic patient will say he has a habit of sleeping on the tummy, on his own tummy, okay? So he has a habit of sleeping on the tummy and the neck get rotated and the structures get stretched and you get the pain.
Thank you so much, sir. With that, we would be ending with the seminar, with the webinar today. I, Dr. Zubia Waqar, General Secretary, DIAP, would like to propose a vote of thanks. Thank you for being with us. It's an honor for us that you thought to be here instead of roaming in cyber lanes, chatting with your friends and family, sleeping, or just sitting in front of the idiot boxes at home, which I'm sure a lot of us are doing otherwise also. Now we have come to an end of this lively and informative academic activity. It might not be suitable to call it a pure academic activity because whenever Dr. Deepak is involved, it's a fun-based learning that we can say more than being a pure academic activity. On behalf of DIAP, I would like to extend a heartfelt gratitude to Dr. Deepak Kumar for delivering the lecture today. We are looking forward to many such associations with sir. Thank you so much, sir. I would like to thank all the executive committee members of DIAP who have put in a lot of effort before and up and during the presentation or preparing for the webinar. I would like to thank Dr. Tanmay for all his planning during and prior to the organizing the entire webinar. Thank you so much, Dr. Tanmay. And of course, we cannot go ahead till the time we thank our model, Dr. Adya. She took out time, wore the mask very nicely for us. Thank you so much, Dr. Adya. Next time, let's hope to see you without the mask. Last but not the least, a thanks to all our participants. And the thanks is even larger because of the sheer number of participants which are there with us. Thank you so much. It was a great success because of all of you who are attended our webinar today.